So we can start now.
Thank you, Mr. And good evening, ladies and gentlemen, and welcome to this STEP program. The topic for today is drug speaker with us, and she's CCM and also a fellow of Indian College of Critical Care Medicine. She also holds a degree of European Diploma in Intensive Care Medicine, and she's an executive member of ISCCM, National and Mumbai City Board. She's also an instructor with AHA, BLS, and ACLS, and is a consultant with critical care at Mumbai. So with these words, I would like to welcome Dr. Gunjan Chanchalani, who's going to talk to us about the drug interactions, because we see quite a number of these interactions happening in the ICU. And we need to be aware of whatever is the problem that we face and how do we counteract each of it. So with these words, I welcome once again Dr. Gunjan and all to you. Thank you once again.
Thank you so much, Dr. Asif. And thank you for the kind introduction. We'll go ahead with the topic. Okay, so my topic for today is what are the common drug interactions that we see in the ICU? There are many, and there are many which we know, and there are many which we do not know, and we have been missing on a regular basis. So let's go through why these interactions happen and which are the common ones and how we can avoid them in our daily practice. Okay. So it has been noticed that 58% of the ICU patients are potentially at a risk of drug-drug interaction. And this number is double of what we see in the wards, more than double of what we see in the wards. That is mainly because in ICU, people are maybe on more of polypharmacy. There are multiple drugs which are there. And all these drug interactions lead to many adverse drug events. They increase the mortality and morbidity, prolong the length of stay in the ICU, and increase the hospital costs. So these drug interactions occur mainly in two ways. Basically, the interaction can be at the pharmacokinetic level and at the pharmacodynamic level. So what is a pharmacokinetic level? Pharmacokinetic is what the drug undergoes in the body. Okay, what the body does to the drug, you can say. So when a drug is given, the drug is absorbed, it is distributed, it is metabolized, and finally excreted. At all these four steps, there can be drug interactions between two drugs. And the pharmacodynamics is what the drug does to the body. That means what is the action of the drug in the body. Okay, so thus the interactions between two drugs can happen even at this level. Okay, so as I said, why are ICU patients more at risk? Mainly because they have polypharmacy. We have multiple drugs which are given to any ICU patients because of the multiple organ involvement that they may have. Also, at the same time, they have impaired hepatic and kidney function, which may alter the metabolism of most of the drugs. And this puts them at increased risks of drug toxicity and drug interactions. So whenever a drug is prescribed on an OPD basis, most of the patients do ask what will be the interactions, is it safe? But these ICU patients, unfortunately, are at unfortunately are not in a position to question. And with the stress level, many family members also are not. So we have to be very alert, or rather, we have to be very vigilant about what the drugs can interact with. So is every drug interaction harmful? No, not all drug interactions are harmful. Some drug interactions may also be beneficial, and they are deliberately given together so that they can add to the effect of each other. Now these interactions can be additive, or they can also be synergistic. Synergistic is when two drugs are given together, the action of both are more than the individual drugs which are given. So when we combine ACE inhibitors and diuretics, it is mainly to treat hypertension. Sulfamethoxazole and trimethoprim, they are combined together because both potentiate the action of each other. And furosemide and amiloride, though they are both diuretics, they are given together to prevent hypokalemia. So some drug interactions are beneficial to us, but there are some which can be risky, and some can be even life-threatening. Sorry. I'm so sorry. Just a second. Okay. So when a patient is received in the ICU, it is very important that we take a detailed drug history of the patient and record all the medications that the patient is on, so that we can be aware of what drugs which we give will not interact to any of the medicines that he was previously on. So which are the drugs which are most likely to be involved in any drug interaction? So drugs which have a very low safety index or very low narrow therapeutic index, these are at a very high risk. So what do you mean by a therapeutic index? So basically these are the drugs which have the action or the minimum lethal concentration of these drugs is very close to this the effective concentration of these drugs. So that means the serum levels where the drug will be lethal or have adverse effects will be almost very close to the level that it is required to maintain the therapeutic concentration. Okay, these drugs are mainly which are used in ICU are mainly digoxin, though it is gone, we use lesser these days, but digoxin is a very important drug with low therapeutic index, and drugs like aminoglycosides and lithium also have a low safety margin. Drugs which affect the vital physiology of the body, that is the blood pressure, diabetes, coagulation, especially the anticoagulants that warfarin, they have a lot of drug-drug interactions, also drug and food interactions that are there. Drugs which have high plasma protein binding capacity will also have very high interaction, because these drugs will displace each other from the plasma protein binding sites and will cause interactions. Namely, here we have non-steroidal anti-inflammatory drugs, warfarin, and anti-diabetic drug, that is sulfonylureas. Then there are drugs which are metabolized by zero order kinetics or saturation kinetics. What do you mean by zero order kinetics or saturation kinetics? So basically there are kinetics, or the drug metabolism can happen by two kinetics. One is first order kinetics, the other is zero order kinetics. What happens in first order kinetics, that if I give a drug in X concentration, the metabolism is X. When I increase it to Y concentration, the metabolism will increase to Y. Okay, so then whatever concentration is there in the serum, accordingly the metabolism of the drug will increase. But when we talk of zero order kinetics or saturation kinetics, that is above a level, the drug metabolism will not increase. That means if I give a drug at X, the metabolism will be at X. And if this effect, or if this has saturation limit of X itself, so when I double the dose of this drug, still the metabolism will remain as X. That means when I double it, the complication will be more than double of what it can be. Okay, I think there's a hand raised. We will take the question right away. Dhaval, can you help us? Mr. Dhaval, are you there?
Such questions from just there is one email ID.
There is a question from the audience.
No question in the chat box.
No, there is a somebody raised the hand.
Yeah.
Because this concept has to be understood well before we go ahead.
If they want to ask the question, they have to type the question in the chat box, ma'am.
Okay. Okay. So please type your question in the chat box. If you, because raise hand, we can't unmute them in case somebody has raised hand.
They'll have to send it in the chat box.
Okay. All right. So I'll repeat what is zero order kinetics again. So zero order kinetics is, that is a saturation limit. That means if I'm giving a drug at 5 and the 1 is getting metabolized and the saturation limit is 2. So when I double it to 10, it will metabolize as 2. That means 20% will be metabolized. But when I'm making this 10 as 20, still only till 2 will get metabolized. So when I've doubled the concentration of the drug that I've given, my therapeutic or the level that will be in the blood will go from 8 to directly 18. Okay. So that is the main worry that we have with zero order kinetics. So phenytoin and theophylline observe zero order kinetics for drug interaction. So when can drug interactions occur? Okay, drug interactions can occur right from the time that you prepare the drug to the time of administration, to the dissolving of the drug in the solvent. They can also occur at the time of absorption if we are giving any orally administered drugs, for distribution, metabolism, excretion, and finally at the pharmacodynamic level. That means at the action level of the drugs. Okay, so we first see each of these interactions, how they happen, and then we will see the common the common drug interactions that we see in the ICU. So in vivo in the body, the in vitro, the drug interactions will occur at the time of dissolving the drug or combining or administration of the drugs. And in vivo, the drug interactions will occur at the pharmacokinetic level, as I told you. That means at the time of absorption, metabolism, excretion, and in the dynamic level, it will occur when they are adding to each other's effect or when they are antagonizing each other's effects. Okay, so this is the pharmacodynamic part of the drug interaction. So types of interactions can either be quantitative, that means they will increase the effect or the side effect of each other, or decrease the effect or side effect of each other, or it may be a qualitative effect wherein there will be a abnormal type of response that may happen. Okay, so potentially the drug interactions happen when you have more than one drug which are administered, and the chances or the probability increases when you have more number of drugs that are administered, when there is a patient who has multiple diseases, when there are multiple doctors involved in it, and this is where the role of intensivist comes, when the patient has compromised physiology, that is compromised organ function, that is hepatic or renal function, and when patients are at extremes of their ages, that is in elderly or in kids. Okay. So now let's understand the first level, that is the absorption level. When you give oral drugs, the absorption usually happens in the gut, wherein multiple drugs will interact with each other and will prevent or enhance each other's absorption. Okay, so when tetracyclines or calcium and iron salts are given together, or when phenytoin is given with sucralfate, these form complexes in the gut which are insoluble and which cannot be absorbed. So the interaction is reduced by administering these drugs at a gap of 2 to 3 hours. Okay, the alteration in the enterohepatic circulation. Sorry. So alterations in the enterohepatic circulation. So this is like when tetracycline, when you give, it reduces the gut flora. Okay, so these gut flora are very important for for deconjugating oral contraceptive steroids, that is the contraceptives. So these, because of the enterohepatic circulation that is reduced in these medicines, that is why their effect will reduce. Okay, I've taken common examples. Now we will go ahead with knowing what are the ICU examples that will be there. Then comes to distribution. So distribution depends on, very importantly, it depends on the plasma protein binding of the drug. Okay, so when especially drugs which are highly plasma protein bound will have low volume of distribution. So primarily one drug may displace the other drug from its binding site. And as we all read, the warfarin, phenytoin, sulfonylureas, certain NSAIDs, they are very important for they are highly protein bound, and therefore they will displace each other from the plasma protein binding site and may cause interactions. Okay, so the unbound fraction is actually the active form. Okay, so when one drug will displace the other drug, the amount of that free form that will be there, or the unbound form in the serum, will increase, and thus the effect and eventually the toxicity of that drug will increase. Okay, we'll come to more examples. When we talk of metabolism, so there are drugs which will enhance or reduce the metabolism of one drug over the other drug. Okay, so the inhibiting drugs will inhibit the enzyme which will metabolize or will deactivate that drug. Okay, so the enzymes which inhibit that drug, if A drug is inhibiting the metabolism of B drug, the effect of B drug will increase and the complications or toxicity of the B drug will increase. If A drug is enhancing the metabolism of the B drugs, then the effect of the B drug will decrease. That means sometimes a pro drug is converted to an active drug. So A drug is inhibiting the conversion to the active drug, the metabolism will decrease. And if the A drug is enhancing the conversion into the active drug, then the toxicity will increase. Okay. So which are the inhibitors of metabolism of multiple drugs? Mainly the macrolide antibiotics, that is erythromycin, that we give commonly, or as erythromycin or oxythromycin that we use commonly for pneumonias. The azole antifungals, that is fluconazole, especially voriconazole, they are strong inhibitors of multiple drugs. Then chloramphenicol, not very commonly used these days, but is coming in vogue again. Omeprazole or antidepressants, that is selective serotonin reuptake inhibitors. HIV drugs, cimetidine, which is a proton pump inhibitor, which is a histamine inhibitor. Quinolones, again used very commonly in pneumonias, and metronidazole. These are inhibitors of metabolism. Okay, so so if patients, like for example, if the person is getting statin, okay, so the statin metabolism is inhibited by erythromycin or azithromycin. Okay, so when we give a statin, if I am not taking care of this inhibition that is there. If somebody co-administers erythromycin to this patient, the complication that the statin induced myopathy, the toxicity of statin will increase. Okay. So these are again the list of inhibitors that are there. Amiodarone is also one of the important inhibitors that we commonly use in the ICU. Then cyclosporin, clarithromycin, verapamil. These are antihypertensives. Voriconazole, as I said, it is also a very protein-bound drug. So it is most commonly a common drug which will have drug-drug interactions in the ICU. Okay. Then what are enzyme inducers? So enzyme inducers like mainly phenytoin, carbamazepine, rifampin. Even alcoholics have high metabolism because their enzymes are highly induced or more active. So these will enhance the metabolism of these drugs, and therefore the effect of that drug will reduce. Okay, so it will take, but if you administer 2 drugs at one time, so sometimes the inducer may take 1 to 2 weeks to act to produce the maximal effect. So that is why the effect of the first drug will start regressing after 1 or 2 weeks of giving that second introducer. So suppose I'm giving an antimicrobial therapy with doxycycline or metronidazole. Okay, so if I'm administering a inducing agent to this, so there will be a failure of this antimicrobial therapy. That means the effect of doxycycline will decrease and there will be a failure of this antimicrobial therapy. We already spoke about contraceptive failure with absorption, but if a patient who's on contraception or is given rifampicin for AKT, the effect of contraception will reduce because the metabolism of rifampicin is an enzyme inducer. So it will increase the metabolism of contraception. Again, chronic alcoholics have inducers of enzyme inducers. So paracetamol, when you administer to these patients, so it is converted to a toxic metabolite. Okay, so because they are enzyme inducers, they will rapidly convert this paracetamol to toxic metabolites. So that is why the toxic dose of paracetamol is lower in the chronic alcoholics, as they will induce the metabolism of paracetamol to its toxic metabolite. Now coming to excretion. Okay. Interaction between excretion mainly is because when the drugs are actively secreted by the kidney in the renal tubules. Okay, so the pH of the urinary pH, if it is altered, it will alter the process of reabsorption. So when there is drug clearance in the kidney, what happens is first the drug is filtered at the glomerular basement membrane, and then in the tubules it is either actively secreted or it is reabsorbed back. So altering the urinary pH will alter this reabsorption of the drug back into the blood circulation. Okay, so like when we have probenecid, if we give probenecid, it will inhibit the tubular secretion of penicillins or cephalosporins. So that means the excretion of penicillin and cephalosporins will reduce, and that is why the toxicity of penicillins and cephalosporin will reduce. Okay, and alkalization of the urine, if we have, it will increase the excretion of barbiturates. Okay, this is what we use when we have barbiturate toxicity. That is why we tell to alkalinize the urine by giving bicarb, so that the toxicity of barbiturate will reduce. Okay, because it increases the excretion of barbiturates. Then coming to pharmacodynamic interactions. Okay, pharmacodynamic interactions is the action of the drugs. Okay, so one drug will, when there are 2 drugs which will act at the same target site, they will change the action of each other, and that is why independent of the change in the concentration of the drug will remain the same, but because they are acting at the same site, their effect will differ, or the effect will get enhanced, or if they oppose each other's action, then the effect will get antagonized. Okay, so they will either enhance each other's response or they will attenuate the response of each other when 2 drugs which are interacting are given together. So for example, when we give benzodiazepines or an opioid together, like when we use sedation in the ICU, we usually use midazolam and fentanyl together. When we administer each other together, they will increase the effect of sedation. They will cause more respiratory depression. So they are enhancing the effect of each other by acting at the same site. Also, when I'm giving 2 antihypertensives at the same together. So when I'm giving ACE inhibitors and diuretics together, or adding alpha blockers and beta blockers to it, so it will enhance the fall in the blood pressure because of co-administration of these drugs. So often we tell we often write to give at different timings. We prefer to administer antihypertensives at different timings to avoid this excessive sudden fall in the blood pressure of the patients. Okay. Also, in many patients, in cardiac patients and all, we usually combine aspirin and clopidogrel because they will enhance the platelet inhibition that is there. But at the same time, they may, if there is a high dose which is given, it may result in bleeding if simultaneously these drugs are administered, especially if they are administered with carbonicillin. Also, if these drugs are given with, because warfarin and aspirin and clopidogrel both have one has antiplatelet, other has anticoagulant effect. So the risk of bleeding will increase if you are giving all the three drugs together. Sometimes these actions may not be very explainable when they may not have a similar effect. So that is why they may not have a similar. So like if we combine metronidazole and cefoperazone, they will inhibit the enzyme aldehyde dehydrogenase, and therefore these patients will have distressing symptoms if the patient is on alcohol. Okay, so these are not very common drugs that we give in ICU, but when let me come to the common interactions that we use in ICU. So I have listed 10 common drug to drug interactions that we see in the ICU. Mainly we have a lot of drugs in the ICU which are QT prolonging agents. Okay, many antimicrobials like quinolones, macrolides, they all cause QT prolongation. Antiarrhythmic drugs like amiodarone, sotalol, quinidine, they cause QTC prolongation. Then antidepressants or antipsychotics, which may use in ICU delirium, like haloperidol, will also cause QT prolongation. And other drugs like cisapride, which we use for increasing gut motility, will cause QT prolongation. So when we combine these drugs, a lot of patients may be on a quinolone or on a macrolide, but the patient is delirious, somebody will come and add haloperidol. So this will increase the QT prolongation in this patient and can lead to even the risk of arrhythmias, which is torsades. So when these drugs are administered, we should monitor the ECG of this patient, or best is to avoid combining these drugs. But in case we have no option, but we have to combine these drugs, then we have to see the QT interval in these patients on an ECG. And if it is going more than 450 milliseconds in the male or 470 milliseconds in the female, we need to be cautious and we need to discontinue the drugs which are causing QT prolongation. So it is very common to combine QT prolonging agents with each other in the ICU. They are very commonly used drugs. Also, electrolyte disturbances like hypokalemia, hypomagnesemia, and hypocalcemia may add to this QT prolongation in the ICU patients. The second common drug-drug interactions that we see in the ICU is with the use of NSAIDs. NSAIDs, as we all know, is a prostaglandin inhibitor, and therefore it has increased risk of gastric ulcer and bleeding from these gastric ulcers. When we combine this NSAIDs with corticosteroids or with serotonergic agents, that is with antidepressants like SSRIs, so they will increase the chances of bleeding from this gastric ulcer. Then a commonly used combination for arrhythmias is combining digoxin with amiodarone. So patient who has atrial fibrillation is not getting controlled with amiodarone. Usually they will combine a digoxin with it. But when we combine both these drugs, the co-administration will increase the serum concentrations of digoxin. And as we all know, digoxin is actually a drug with a very narrow therapeutic index. We heard about a therapeutic index a few slides back. That is, the serum concentration of digoxin will increase if we co-administer amiodarone, and that the digoxin has very lethal side effects or lethal toxicity, and this will increase the chances or higher risk of digoxin toxicity that will be there. Digoxin toxicity can cause tachyarrhythmias as well as bradyarrhythmia. So digoxin is a very highly toxic drug, but sometimes when the arrhythmias are not controlled, like atrial fibrillation is not controlled, many cardiologists have a tendency for adding amiodarone, adding digoxin as a second drug to control the arrhythmias, but it can increase the toxicity at a very higher level. Okay. Next is combining NSAIDs with antihypertensives. So antihypertensives, NSAIDs, as I told you, will act on the renal prostaglandins. So the antihypertensives which act on renal prostaglandins, that is the furosemide or ACE inhibitors, these efficacy of these medications will reduce when they are combined with NSAIDs, because NSAIDs are antiprostaglandins. So this will cause an increase in blood pressure. They will cause increased fluid retention and also will increase the risk of acute kidney injury. Okay. But when NSAIDs are combined with beta blockers, it will also attenuate the effects of beta blockers as well. Okay, so when you combine NSAIDs with most of the antihypertensives, what we notice is there is an increase in blood pressure, there is more fluid retention, and the chances of acute kidney injury increase. Okay, next is combining digoxin with macrolides. Again, so we all know that macrolides are enzyme inhibitors. So that will enhance the effect of digoxin. But also when given orally, when macrolides are co-administered with digoxin, the oral bioavailability of digoxin is increased. The reason being that macrolides will alter the gastrointestinal flora, which makes digoxin less active. Okay, so the gastrointestinal flora is killed by this macrolide, and that is why the bioavailability of digoxin is increased, and this will again cause digoxin toxicity. Then combining haloperidol, that is the serenase, with enzyme inducers. When we give serenase with these enzyme inhibitors, the plasma concentration of haloperidol will increase. Oh, sorry, the plasma concentration of haloperidol will decrease, and that is why its efficacy will reduce. Then combining thyroid hormones with antacids or other calcium preparations. So as the age advances, most of the patients will come to us with L-troxin, and we'll also have calcium preparations with them because of osteoporosis. So when we administer this combined, the calcium preparations will reduce the absorption of thyroid hormones. So when we are giving these two drugs together, there should be a gap of 3 to 4 hours when we are administering both these drugs together. Okay. Combining phenytoin with various inhibitors. Phenytoin, again, as I said, is an enzyme inducer, as well as it is highly protein bound. Also, it has saturation kinetics, that is zero order metabolism that we have heard of. So it is a drug which is very, very commonly known for its drug-drug interactions in the ICU. So as we all know, it has a saturated kinetics. That means if I increase the proportionately increase the concentration or administration of phenytoin, its kinetics or its metabolism will not increase with the same proportion because it gets saturated. Okay, so this will lead to increased toxicity of the phenytoin concentration. So there will be marked changes in the serum phenytoin concentrations, and this will increase circulating phenytoin concentration and will increase its toxicity. Okay, so various inhibitors that are there, even other anti-epileptic drugs are enzyme inhibitors that are there, and that will cause increase toxicity with phenytoin. Fluconazole, voriconazole are known to cause it. Other important for us is cimetidine, that is H2 antagonist, and omeprazole, which is there. And when we give sulfonamides as antibacterial drug, so when we use for and as an antibacterial, it may, though they are not very commonly used, just except for Septran, that is the sulfamethoxazole and trimethoprim, we do not use other drugs very commonly in our ICU. So these will enhance the toxicity of phenytoin by decreasing its metabolism. Phenytoin, as we all know, itself is an inducer, and also it will change the metabolism of other drugs, and it will also interact with other drugs in the same way. So this phenytoin, by inducing enzymes, will decrease the levels of drugs like carbamazepine, oxcarbazine, topiramate. These are other anti-epileptics. It will decrease the effects of statins. Okay, it will decrease the effect of calcium channel blockers and other drugs like cyclosporin, which is an folic acid, praziquantel. These are important drugs which we commonly use in the ICU, and it will reduce this effects. When you combine phenobarbital with valproic acid or sodium valproate, the effect is often unpredictable between each other. Okay, so it is best that we avoid combining phenytoin with a valproate. I've come to this side. So they have two separate and opposing effects. When we combine phenytoin with valproic acid, there is separate and opposite effect. So that means what happens is when we give them together, the valproate will displace the phenytoin from the plasma protein binding site. So this will increase the systemic clearance. That is, the drug which is excreted from the kidney unchanged, that it will increase. Okay, but at the same time, valproate will inhibit the metabolism of phenytoin, so that it will increase the concentration of the free drug in the serum. Okay, so what effect it will have, it is often unpredictable. Now these are the most 10 common effects that I told you all. So as most what was more surprising is before the administration. Okay, the drug compatibility that we talk of. Okay, the in vitro drug-drug interactions which is there, that is drug interactions which happen before administration, which is also known as drug compatibility. Okay, certain drugs often react to each other when even in vitro, when we dilute them together or when we administer them together with the same through the same IV cannula or through the same port of the central line, they often interact with each other when and they may either precipitate or change their color. So this is a drug interaction which will happen before administration, and it is this term is also known as drug compatibility rather than drug interactions. Some examples here I've given is penicillin G or ampicillin when it is interacting mixed with gentamicin, when thiopentone is mixed with succinylcholine or morphine, and when heparin is mixed with penicillin or with hydrocortisone. So these are common drug interactions that we see. What is more surprising is the incompatibilities which is given in this slide. If you see, most of these drugs are incompatible with pantoprazole. Pantoprazole is so commonly used in the ICU that we do not think twice before co-administering with any other drug. But if you see it as interacting with many antibiotics, meropenem, clindamycin, piperacillin, tazobactam, metronidazole, amikacin, fluconazole, levofloxacin. So it is very surprising that we are so subconsciously giving pantoprazole to every patient, and we are not giving it a second thought whether when we are co-administering them, that they are incompatible when we co-administer them with through the same IV line. Also, another commonly drug used is ondansetron, that is MSET, which we commonly use. That also very commonly is incompatible with meropenem and ceftriaxone. Then midazolam is incompatible with piperacillin tazobactam, and Lasix of furosemide is incompatible with thiamine. Okay, so these are the common. So even when we administer pantoprazole, we have to think twice which we are combining with. Lasix is also incompatible with pantoprazole. Okay. So to conclude my talk, not all patients who are taking drugs will experience adverse consequences when we give them, when they interact with each other. So when drugs are interacting with each other, not all patients will interact, all drugs which are interact with each other will cause toxicity in these patients. But we should remember that two drugs will always have a potential to interact with each other, but they may not always contradict their concurrent use. We just have to time them to as so that they do not interact and do not have complications, or we need to adjust their doses accordingly. We need to remember have the knowledge. We need to be aware of what the interaction is and accordingly take corrective steps up to prevent these interactions to happen. So it is prudent to consider the possibility of drug interaction when we give 2 or more drugs are prescribed to a single patient, or when any second drug is added to a patient to what the patient is already taken. Okay, so as you can see in this cartoon, one prescription is for arthritis, the second, but that may cause a heart attack. The second prescription is to prevent that heart attack, but it may affect the liver. So the third will prevent that liver complication, but it will affect the spleen, and finally the fourth will prevent the spleen complication, and that will give. So eventually, are we giving more drugs to prevent interactions, or we giving more drugs to prevent each other's complications? So that is a big question which is unanswered. Now we'll take questions from the audience. I think Dhaval have to unmute because typing may not be very easy in this kind of a topic. What do you say, Dr. Asif? Dr. Asif has lost connection. Dhaval, please try to unmute people who are raising hands. Achha. If you have any questions, you can raise your hands or you can type in the chat box. Can we take Dr. Asif online if he has anything to add? Have you all experienced, let me ask you all a question. Have you all experienced any drug incompatibilities when you're administering? Can you all tell us anything about your experience? You can type.
Yeah, Dr. Gunjan. Yeah, good evening, Dr. Asif again. Can you hear me? Yeah,
Yes,
there
we
was
can
a
hear you,
connectivity issue. Yeah, that's why I could not get through.
Yes.
So first of all, thank you very much. Elaborate topic and very well covered in a very comprehensive manner. And we tend to neglect it at all levels, the interactions and the drugs which are involved in there. So what I have to say that you have covered it very well, and you have in fact given very good examples of the different combinations which are in use where we have a potential drug interaction. What are the different problems which can happen and how we need to be careful about it. So I think very well covered from your side. And since we're not having any questions, but I think we need to understand that this is something which we cannot do it in a day. In fact, the matter of this presentation, whatever has been told by Dr. Gunjan, we should take note of that. And on a day-to-day practice, we should actually apply it whenever we are going to prepare drugs, whenever we're going to give drugs in there. So I know this is something which has not been covered extensively earlier, nor the people do give importance, but working in ICUs where you have multiple problems. So you need to be careful about how these aspects are to be covered. And thank you once again, Dr. Gunjan. So if people have,
I think if you all have questions, if you all don't have questions, you can share your experiences, which you have had with drug incompatibilities or toxicity because of two drugs being given together. About sharing the PowerPoint, I can send it to education@iccm.org, and you can send your request that you want the PowerPoint. I can send it to them. They can share it to you. I have no issues with that. This is a very dry topic. I can just list you all, but I tried to explain the concepts as much as I could. If you all have not understood any concept, that also you can ask me in the chat box about pharmacokinetic or pharmacodynamics, then I can explain that once more.
so since they're not asking Dr. Gunjan, how can you make it practical and easy for them to take this aspect?
I think then we end. Just ask Dr. Asif, he's coming back. Dhaval, he's back.
Yeah, anything more, Dr. Gunjan?
No, nothing more about the practical aspect that you asked. Okay, I'll just answer the question which he said. We need to remember the common drugs which interact. For me, if you ask me, I did not know so many interactions before I took the talk. I started to know about the interactions as I kept reading it. And it was a surprise for me to know that pantoprazole interacts with so many drugs, which we tend to give it so subconsciously in our ICU. Okay. What is more important, what rather I remember is the drugs which are more commonly have interactions, or the few drugs which I always remember to check for interactions is mainly when we give erythromycin or azithromycin, when we have digoxin, voriconazole, phenytoin, and warfarin. Also for incompatibilities, heparin and furosemide. These two drugs are for incompatibilities, and these 5 drugs are for interactions. These are the common drugs that we need to remember for interactions as well as for interactions. Dr. Asif, are you there?
Yeah, I'm there. So any more clarifications required? I think nicely covered and very good.
I just told them ki it's very difficult to remember a complete list of drugs which are interacting between each other or which will be incompatible. It was a surprise or a shock to me when I came to know about pantoprazole interacting with so many drugs or being incompatible with so many drugs, to be precise.
True.
What we as a common, since it's difficult to remember so many drugs, the 5 main drugs which I remember as which will interact with most of the drugs is ones which have high protein binding or which have narrow therapeutic index. So of this, which I usually tend to remember a lot, is mainly macrolides, and macrolides and quinolones in one group, warfarin, phenytoin, digoxin, and voriconazole. These are the main 5 drugs which usually interact with many drugs. And anti-epileptics, phenytoin will include anti-epileptics, that is valproate also. Okay. So, and then for drug incompatibilities, furosemide and heparin are these 2 drugs which are mainly incompatible with majority of the drugs that we use in the ICU.
Yeah, I think these are the most common ones which we are using, and we have to be very careful about all these parts, and more so above and over whatever drugs we have talked about. In fact, the list that you have presented, people should take a cue of that and also have a more detailed experience and a practice in their day-to-day practice.
Yes.
So I think if you don't have any questions, can we?
Yes, we can
come to the end of this program.
Sure.
So, Dr. Gunjan, thank you once again. It was really heartening to go through the drug interaction, the basics.
I think we end it here. Dr. Asif has a very poor connection. Thank you very much, everyone. Okay, have a safe drug administration in the ICU. Thank you, Dhaval. We can end it.